And I muted everybody, so if you want to say something, you'll have to unmute. All right, so about 20 years ago, CMS came out and realized there were some problems with surgical care. And they went through and did some things to try and come up with kind of a best practices, if you will. So part of that was what was called the Surgical Care Improvement Project, or a SCIP. You may also see it referred to as SIP, or just Surgical Improvement Project. But you'll hear people talk about SCIP, you'll hear them talk about core measures, you'll talk about things you have to do. And we're just going to kind of walk through some of the common ones. With that in mind, this is a constantly evolving project. So at the end, we're going to talk about SCIP 2021, which is the latest, and I'm not sure if it's really greatest, but the most current version of it. So background, one of the biggest problems we run into in surgery is postoperative infections. And we know that each infection generally results in the patient being in the hospital at least 7 days longer. And it also increased cost by at least $3,000, and by now it's probably gone up quite a bit from that. The problem is some of these patients come in either infected or predisposed to infection. So it's not the most valid information. It's definitely a good concept, but there's some problems with it. The other thing you see is that as complications increase and the patient winds up staying in the hospital even longer, generally when they hit about 30 days of increased stay, their survival rate drops pretty drastically. So we know there's adverse events from being in the hospital. So we're trying to get people in and out as quickly as possible. And that really comes into play in a little bit when we talk about the ERIS stuff, and kind of how we can get people out of the hospital faster, how we can save money for the facility, and how even though doing some things that may be a little bit more expensive at first, may be better off down the line. So when they came out in 2002, it was a combination between CMS and the CDC, and their overall goal was to decrease the morbidity and mortality of surgical site infections. And they thought they had some pretty good ideas of how to go about doing that. And you'll see even when you get to clinical practice now that there's still quite a bit of variation. Hospitals on their own have kind of come up with tightened controls to try and improve things. One of the biggest ones being what antibiotic, when it's given, how it's redosed, and is that antibiotic appropriate for that type of surgery. And I know this will shock you, but they get a lot of pushback from surgeons who feel like they want to do something different or have a different concept, but they aren't willing to support that idea to like the Hospital Infectious Disease Committee or the Antibiotic Committee or whatever they happen to have there. So the original performance measures they looked at was trying to figure out how many patients were getting antibiotics within 1 hour of incision, the proportion of the antibiotic regimen that was really consistent with guidelines, like I said, the appropriate antibiotic for the appropriate surgery. And then afterwards, whose antibiotics were discontinued within 24 hours of the surgery stop. Because one of the problems you run into is if you put people on extremely long courses of antibiotics, they tend to become resistant to that, especially in their hospital stay where they can be exposed to different pathogens that are already microbial resistant. So why did they pick those? One of the big things was that they knew that the timing of the antibiotic infusion and the selection of the appropriate antibiotic resulted in an increase in surgical site infection. So if you didn't have that right antibiotic or you weren't starting it in the appropriate time frame, there was an increased risk of infection, which just kind of makes sense. The general standard for that is that you need to start the antibiotic and complete it no less than 15 minutes before the surgical incision, but no more than an hour. So you've got about a 45-minute window to try and get antibiotics in there. Where you tend to get into trouble with that is something like vancomycin, where you can't infuse it quite as quickly. So with that, a lot of times what will happen is it's either started in pre-op, or you'll start it, and it continues for quite a while, usually an hour or two. But it also has a longer duration of action. The other thing is, depending on the procedure, generally with vancomycin, it's either somebody that's either high risk for infection, or they're perhaps already infected or resistant to standard antibiotics. The second thing was the duration of prophylaxis, so how long were they getting antibiotics for? And what they found was that if you continued antibiotics for too long, you had an increased risk of bacterial resistance. So it seems kind of counterintuitive, but more antibiotics were not necessarily better. So there was a review in 2001, and this is what they based a lot of the information off of. It was 34,000 Medicare patients with a variety of surgeries: cardiac, vascular, abdominal stuff, colorectal, hips and knees, and then GYN stuff. With that being said, only about 55% of those patients got their dose within an hour of incision, and only 92% of them actually got the correct antibiotic. And then this is where it really came into play, that only about 40% of those patients had their antibiotics discontinued within 24 hours of the surgery stop. So when you start looking at these surgeries, as I mentioned, some of these patients either come in and they're already infected or they're high risk for infection. So these rules still kind of apply, but at the same time, they're also a little bit different because those patients may need an infectious disease consult. They may need more specific antibiotics tailored to whatever bacterial growth they have. So there are outliers. These are just kind of a standard approach to patients to get everybody a little bit closer to being on the same, more appropriate page. But what you see a lot of times, it's going to be orthopedic patients or kind of trauma general surgery patients. They come in with contaminated wounds. You know, maybe they've literally been laying in the dirt. They've got exposure to outside pathogens. And as a result of that, they're already at an increased risk for infection. Then you add in poor tissue integrity as a result of their wounds or exposure to hospital pathogens, and they're, again, very high risk. So this is just kind of showing you some of that data there from subsequent studies after they started looking at this. And they had a little bit of improvement in things. Patients were getting better antibiotics. They were being stopped within the appropriate time frame, and they were getting them administered within a reasonable amount of time. But when you go back and look at this data now as compared to then, you'll see that it's significantly better in most facilities. Like I said, there's still exceptions. So what is the actual process? Because as I said, this is not just a single event. This is an ongoing improvement process. So it started in 2005 with data from the early 2000s because things weren't improving just by coming out and putting out this position statement. And so they were looking to try and reduce surgical morbidity and mortality. Part of that is unfortunately not altruistic. They were trying to save money because of the cost of complications. And there was pretty significant opportunity for improvement. And you'll see that even though we make a big deal out of this, it's really little things for us to do. None of it is really labor intensive, and it results in a lot better outcomes for our patients. And their goal was to reduce surgical complications by just 25% in 5 years. So who all they get involved? As I said earlier, they brought in CDC, they brought in CMS, they brought in the College of Surgeons, the American Hospital Association, ASA, AORN, a whole lot of great organizations on there. But there seems to be one big one lacking there. And I'm going to get on a soapbox for a second. You'll see that historically as CRNAs, we've been willing to kind of take the second chair. We don't advocate for our patients. We don't advocate for our profession. This was a great opportunity for us to get early on involvement in this project, and we didn't do it. With that being said, when you actually look at the things they were targeting, we're the ones completing a large portion of these tasks, and we didn't even have a seat at the table. So when you graduate and when you get out of here, take every chance you can to advocate for not only your patients, but your profession. Get involved on hospital committees. Take legislative action. Get to know the people in your community that are kind of the movers and shakers. Because every time we miss a seat at that table, we're letting somebody else make decisions for us. All right, so out of everything, they came up with a recommendation to administer a prophylactic antibiotic within 1 hour of incision. As I said, vancomycin allows a little bit longer window just to the increased duration of administration. Go ahead and give a correct antibiotic based on the procedure, and then discontinue it as long as there's not like a documented infection or a suspected infection. Those patients have already kind of fallen out. And then you'll see that for cardiac surgery, we continue it just a little bit longer. So instead of doing 24 hours, they'll actually do 48 hours for cardiac surgery patients. So antibiotics were the first thing they really focused on. The second thing they looked at was beta blockers. And this is for patients that were already on beta blockers. And one of the things that they originally thought was that it was extremely important for all these patients that were on beta blockers to continue to take their beta blocker within 24 hours of surgery. And what you would see was if they weren't taking a beta blocker, it was incumbent on us to actually administer a dose of beta blocker. So unfortunately, most of these patients had kind of wide cardiovascular swings, but you had to administer some sort of beta blocker. So what you would see is like somebody would either falsely document that they gave X medication, or they would give something silly like a milligram of esmolol. Reminder that like the effective dose is usually 10 to 20 milligrams, but they would do stuff like that so they could literally check the box and not get in trouble. And then the other thing is that if the beta blocker had been paused, meaning they didn't take their traditional PO beta blocker, that they got restarted on that right after surgery, so they didn't really miss a dose there. Another thing we moved, which probably wasn't a bad idea, was going from shaving patients. We quite literally used to use a safety razor to shave patients to using clippers. And what they found was using that safety razor resulted in microtrauma at the skin, and that increased the risk of infection at their surgical site. Transitioning to clippers seems to have decreased that. But with that being said, you'll still see times where patients don't have appropriate prep done. Maybe they don't have the clippers available. So again, this is an area for improvement if we can continue with that. And that's just the surgical site. I mean, we're not clipping the whole patient's hair or anything silly like that. One of the other things that evolved out of it was evaluating who we were putting Foleys into and how long those Foleys were staying in place. Again, we're targeting infections here. So what you'll see is that we're trying to put less Foleys in patients and then get them out a little bit sooner because they increase the risk of UTIs. So a lot of times for shorter surgical procedures, say less than 2 or 3 hours, we're not putting catheters in. They may use, see if they can get the patient to void before they go to the operating room, or they may not put a catheter in and just let them void afterwards. Sometimes you'll see that they have to put a Foley catheter in for surgical exposure. Say, for instance, they're doing a laparoscopic procedure. They may put a Foley in to decrease the size of the bladder and reduce the risk of perforating it with the trocar. But again, they'll take that at the end of the case. And then patients that are keeping catheters in, it had always kind of been a nursing-driven action as far as when the Foley was taken out. Now we're trying to get those catheters out as soon as possible, no less than a day or two. And if for some reason the patient needs to keep the catheter, there needs to be an order in place for it. So think about somebody that's maybe getting continuous bladder irrigation, maybe they've had a bladder rupture, something like that. And we want to make sure that we're documenting why it's in there and making sure that the patient's getting it out at the soonest possible time. The other thing that really comes into play a lot of times for us is evaluating fluid status. So if you have a minor case, you may have to look to something else, non-urine output, to evaluate your patient's fluid status. Like I said, you can encourage them to go to the bathroom before they go back to the operating room. You can encourage them to go to the bathroom when they get to recovery. Sometimes you'll have patients that's really the first thing they want to do, and they get there and they're not necessarily clear about it, but you'll notice that their heart rate's up, their blood pressure's up. They're not in any sort of pain, but they just need to pee. So you may kind of hose yourself, and we'll talk about it a little bit when we do PACU stuff, on evaluating why patients are really having trouble. Ray had asked, so if you don't finish antibiotics, increased resistance, prolongs antibiotics, increased resistance. Yeah, so if you don't take enough antibiotics, like you underdose, or like, I think he's referring more to like oral antibiotics where you didn't finish out the whole prescription, you have increased resistance. And then on the other hand, if you don't stop the antibiotics when they should be, you give that bacteria time to develop resistance to it. Richard asked, on our other slide set for antibiotics last week, it was Vanco and fluoroquinolones. Do we add clindamycin as well, making 3 antibiotics that have a 2-hour window? Vancomycin and clindamycin are the big ones that I've seen. But what you'll see as far as antibiotic administration and anesthesia, things are all kind of relative. You're not at the bedside anymore, so you'll see that medications may be given a little bit faster. Say, for instance, cefazolins. In the past, you'd put up a 50, 100 ml bag of Ancef and then drip it over, 20, 30 minutes to an hour. Now you're actually going to be drawing that up in a syringe and pushing it. So things are given a little bit faster. Likewise, with vancomycin and clindamycin, you'll see that those are really given about as fast as the patient will tolerate. So if you have somebody that's sensitive, they've got a history of red man syndrome or some sort of histamine release, you're probably going to put it on a pump But in reality, you're probably just going to put it on a mini drip and just let it go in slowly. It may not be that hour or 2 hours, whatever is suggested. It's probably going to be a little bit faster than that. But you'll see how that kind of plays out. And it also varies from one clinical location to another. The pharmacies are pretty tightly involved in antibiotic dosing and schedules for that. So you may see that there's a significant change there. The other thing you may see is, depending on the patient's history, they may alter dosage. One of the big things is stuff that's renally excreted. So if you have somebody with renal issues, they may decrease your dosage because it sticks around a little bit longer. So one of the other things we looked at was, we called it tight glycemic control at the time, but it was primarily aimed at cardiac patients because a decent number of them were also diabetics. And what we were trying to do was keep their blood sugar within a very tight set of parameters. Originally, we were trying to keep them in a range of 100 to 140. It was pretty common to put these patients on insulin drips, and you might be checking a blood sugar as often as 15 minutes or every 15 minutes. So you can imagine how labor intensive that was to do. And over time, what we figured out was that it really wasn't quite as effective as we thought it would be. So we kind of backed off of that. The other thing you'll see is a lot of these patients come in with out of control sugars. It's not uncommon to see patients come in with sugars in the 300 to 400 range, and that's where they live. So if we go through and we correct them to kind of what they should be quickly, you'll see that those patients tend to have neuro effects. They may become altered. They may become almost like transiently hypoglycemic because their body's not used to having the sugar that low. So right now, generally what you'll see is that depending on the facility, you're going to keep your blood sugar less than 180 to 200. And we don't do quite as much management of hyperglycemia in the operating room. On the other hand, and we'll talk about it when we get to the ERA stuff, we're trying to screen out and manage patients a little bit better preoperatively. So we're getting them into a pre-op clinic to see what their blood sugar is, see how we can adjust it, see what we can do to maximize them beforehand. Because what we figured out is sending them out to a cardiologist or their PCP to try and make sure they're in the best possible shape before surgery really doesn't get us anything. You get a piece of paper with a clear for surgery, but they haven't actually done anything to improve the patient's condition. So it's incumbent on us as anesthesia providers to step up and kind of fill in the gap there. Another area we were getting into trouble with was DVTs. So there were kind of a couple different approaches we took. You had chemical and mechanical prophylaxis. So mechanical, think about devices. So you would see that patients were having either TED hose or SCD, sequential compression devices, placed for any sort of surgical procedure lasting more than an hour. Sometimes the patients would come in and have these put on in pre-op. Sometimes they wait till they get to the operating room to do it. Other times they were just coming in and wearing TED hose. And again, it really fell out a lot of times to kind of the surgeon preference. Some people would have folks doing both. They would have TED hose on and SCDs. It's turned out that that's probably not quite as helpful as we thought it was. And then the other thing was that we started to use some chemical or pharmacologic prophylaxis for these patients. So you would have folks that came in that weren't on any sort of anticoagulation, and they would get like a one-time dose of 5,000 units of heparin. And the intent there was that in that limited period of time, while they weren't quite as active as usual, that they would get some sort of anticoagulation coverage to reduce their risk of DVT. The reason they traditionally went with heparin was it was easy to reverse as needed. So if you got into the operating room and wound up having some sort of bleeding, you could always administer protamine. But it was pretty common for these patients to come in and, like I said, either get a one-time dose of heparin or like a 24-hour series of doses of heparin, just as some sort of chemical prophylaxis for DVT. When you start looking at areas, I think this is one we still continue to kind of fail at. Not necessarily just because of the surgical aspect of it, but I think we don't do a good job of getting our patients mobilized. And the other thing is, I think a lot of times that our vascular access tends to be problematic for us. So we're putting lines into patients, those wind up with clots on them. They wind up showering clots at some point during their hospitalization. So one of the things you will see is that there's kind of a decreased emphasis on placement of central lines. And if we do put those in, we try to get them out as soon as possible. Temperature measures, this is a big one for us. because if you've ever been in the operating room, you know it's nice and cold. But what we want to do is try and maintain normothermia for patients. So when patients get out to the PACU, we want to have a temperature over 96 degrees, basically as soon as they get there. So you'll see as you start documenting vital signs that's really a big one for us. The other thing is not only because it's important to the patient, but there's some financial aspects we're going to talk about in just a minute as well that's kind of tied into it. So things we do to keep our patients warm in the operating room. Active warming, you may see some patients are pre-warmed. For instance, at JPS and some other facilities, we have little bear hugger gowns that go onto the patient. So they'll actually hook them up in pre-op. So they're pre-warmed before they go to the operating room. It's nice for them because they've stripped all their clothes off and they're essentially butt naked on a cold stretcher. So having that warm air there is kind of helpful for them. And then they get to the operating room. Obviously, it's cold on the way back there. It's cold when they get to the operating room. Trying to get them warm as soon as possible. In the last couple of years, this has kind of turned into a tenuous one. If you've watched any sort of commercials, one of the big like ambulance chasing things that came out first was, was your loved one exposed to a bear hugger during their total joint procedure, blah, blah, blah. We'll make you millions of dollars. I mean, we'll make us millions of dollars. So you'll see that out there. And I do think there is probably some sort of increased risk of infection from bear huggers or active warming devices because they do circulate the air. If you've ever taken a patient and, you take off their socks, take off their clothes, and it's like snowing with all the little skin flakes, I think that's probably a bad thing to put in the middle of your surgical field. So kind of the standard practice now is we'll put our warming devices in place, whether it's a bear hugger or something else. And if it's something that's going to circulate air, we will wait until the patient's prepped and draped. So you've kind of isolated the surgical field before you turn that on. There are alternative warming devices out there. I used to call them K-pad warmers, but like a warming blanket that circulates hot water. You can put that underneath the patient. And that's something you can start immediately because you're not going to have all that air circulating around. A lot of times, if I have a trauma patient or somebody that's really sick, I'll use a series of things. So I'll put down that K-pad warmer underneath the patient, and then I'll still put bear huggers over top of them. I will also go ahead and wrap their head up because that's one of the biggest areas they lose heat. So I'll take a blanket and wrap it up. I don't need to look at their head while they're asleep. So that keeps the warm air in there. And then remember that anything you're putting into the patient, if you can warm it up, that also helps reduce the risk of temperature dropping during the case. Just following up on a couple of comments here. Yeah, it's interesting when you start looking at different places, what they do and what they don't do, as far as talking to patients about things that are beneficial for them. And like I said, we're really going to go through the standards when we get to the ERIS talk after this. And then Erin's comment was the hospital she was at actually put a thermal blanket on the patient in pre-op as well. I think you're going to see more and more of that. Originally, it was just kind of at the nice hospitals. But if you go out and look at facilities, you'll see there's kind of like specialty hospitals that are targeted at one thing. Maybe it's neurosurgery, maybe it's total joints, maybe it's ENT. And they've really kind of streamlined and maximized the process. And there's a couple things they've improved there. One, and probably the most important for a lot of people on that end, is that they're making more money for them. They're losing less money. But the other thing is their patients have better outcomes. They get in, they get out. They've got a group of specialists taking care of them from the time they get there to the time they leave. So the patients are more satisfied. And I think you're going to see a lot of those kind of behaviors from those facilities carry over to everywhere else. And this is one of those. So there was a couple things that this study went back and looked at, and they were evaluating the temperature measure specifically. Large number of patients that they looked at, and what they found originally was that there weren't a whole lot of values. The study was repeated by another group about 5 years later, lower number of patients, but they specifically looked at that temperature measure. So the reason I've stressed a whole lot of these to you, one, it's important for patient outcomes. We obviously want our patients to do better. We got into this because we were interested in helping people, not just collecting a fat paycheck, I hope. And what you will see is, depending on the group and the practice, part of your financial reimbursement is tied into the outcome measures or these core measures. So you may have heard bundled payments referenced. So say I go into a hospital and have my gallbladder taken out. The insurance company is going to pay X amount of money for that procedure and everything associated with it. So they're going to pay in that amount the surgeon, the anesthesia charges, and everything else. So whether I stay in that hospital for 5 hours or 5 weeks, the hospital is going to get paid the same. So you can see how it's obviously in their best interest to get patients in and out quickly without having any sort of adverse complications. Because the second part of that is if they come in and they go home and they come back, say with a surgical site infection or some other measure, they still lose money for that. So there's a financial interest for all these facilities for patients to not only do well, but also to meet all these measures, go home healthy and not come back. Depending on where you work, you'll see that there's some factors the hospital may not necessarily control, especially what happens after patients leave. We have patients that don't take care of their blood sugar before they come in. We don't really expect them to take care of it when they leave. So there's kind of some innovative approaches going on right now. You're seeing some of the hospitals setting up their own home care programs, not necessarily home health, but somebody is going out. Sometimes it's a nurse, sometimes it's a nurse practitioner or a PA, sometimes it's a paramedic, and they're going out and following up with that patient. So they're going to try and manage things at home to keep that patient from bouncing back. So it may be going home and making sure they're actually checking their blood sugar, looking at their blood pressure medications to make sure that things are well controlled. But it's kind of interesting, and I think we'll see more and more of that happen over time. Like I said, there's a lot of, especially with COVID, kind of blossomed this because people were going home on oxygen as opposed to being in the hospital. So, if, say for instance, you had somebody that was amenable to going home with like 2 to 4 liters of oxygen in a pulse ox, they could do that, and then they would have somebody come back and check on them. So instead of sitting in a hospital bed, taking up space, potentially becoming exposed to something else, they would go home with help. So I think we're going to see more and more of that over time. And I'm going to kind of talk through the Scip 21 stuff here in just a second, and we're going to talk about some specific anesthesia indications and where we get ourselves into trouble. So this is kind of the revision for Scip 21. And one of the things you see here is that we've kind of moved not only to before incision, but also after surgical stuff. So a little bit more of that stuff I talked about, what happens afterwards for the patient. So administration, 1 hour before incision or 2 hours for vancomycin or clindamycin. So like I said, this is going to need to be infused generally no less than 15 minutes before incision and no more than 1 hour. Something else you'll see is that sometimes, depending on the procedure, you may actually have to get the antibiotic in, not so much before incision, but before procedure start. So I'm going to give you for instance, you have a patient coming in for a knee replacement, and they intend to use a tourniquet. You need to have that antibiotic infusion in place prior to the tourniquet going up, because obviously when the tourniquet goes up, it's going to shut off blood flow to that extremity. So that means no more hard circulating ANSEF to the surgical site. So you may see there's some variables there depending on what's going on. It may not necessarily be incision, it may be tourniquet time. Now, with that being said, tourniquet time and incision are generally pretty close to each other. If not, there's probably another issue that needs to be looked at there. As I said, correct antibiotics. In almost every hospital you go to is going to have an antibiotic table or an antibiotic nomogram for you to follow. For instance, you're doing surgery X, Y, and Z. You need to give cefazolin every 8 hours. And a lot of times what you'll see is that while they're in the operating room or in that immediate perioperative period, we redose a little bit sooner. So you may see that antibiotics are redosed at 3 hours or 4 hours as opposed to 8 hours. Again, discontinuing antibiotics within 24 hours of surgery for general patients, 48 hours for cardiac surgery, unless there's a documentation of existing infection or suspected infection. Beta blockers taken within 24 hours of surgery start for everybody that's on them, and you're going to have to document that where. Restarting your beta blockers post-procedure and documenting it, making sure hair gets clipped, Foley's out as soon as possible if they're even placed, keeping blood sugar within 180. The Scip measure is actually for cardiac surgery, but you'll see that most patients are kind of held to that same standard now. So we're generally trying to keep our blood sugar less than 180, especially within that first 24 hours of surgical procedure. SCD patients, there are some variations to that. For instance, if I'm going in to have a cabbage done, they're probably going to prep both my legs, so they're not going to put SCDs on. On the other hand, I worked with a cardiac surgeon that would put TED hose on everybody, and at the start of the procedure, they would cut the TED hose off to gain access for vein harvesting. A lot of times for pediatric patients, because of their decreased risk of thromboembolism, we don't use SCDs, and likewise, they may not actually receive any chemoprophylaxis either. But you'll see as they're in the hospital longer, they're more immobile, that it's pretty common for them to start getting SCDs and some sort of prophylaxis. Vascular surgery patients may not have SCDs placed, again, generally primarily due to the surgical site itself. Giving whatever the appropriate DVT prophylaxis is. And if you're not giving both chemical and mechanical, a lot of times they want you to document why. And there are reasons for these things. You'll see that almost every one of these, it's okay not to do something. You just have to have a valid reason for why you're not doing it. So I'm going to take you through kind of a couple of the ones that get us in trouble. We talked about antibiotics. Hopefully everybody understands that pretty clearly. Make sure, again, you're giving an appropriate antibiotic. Sometimes the surgeon may want to give a different antibiotic because of reason X, Y, and Z. From our standpoint, the important thing is to make sure you document why you gave a different antibiotic. Surgeon requested it, and you may see that they get the surgeon-specific antibiotic and then the antibiotic that's indicated for the procedure as well. But just make sure you document whatever the reason for that is. Beta blockers are generally documented in our preoperative note. Some places you'll go through and like your EMR will have a hard stop there. So you have to document a beta blocker either being taken or reason for not taken. Say, for instance, the patient was already bradycardic or hypotensive. Probably not a good decision to give them a beta blocker at that point. But they just want it documented if it was given, what was given, when it was given, and if it wasn't given, why. And again, that kind of lets us off the hook for things. And then one of the other big things that you'll see is post-procedure temperature management. And this is kind of a pet peeve of mine. So you take a patient to the operating room and, you do surgery, whatever, great. You do everything you can to keep them warm. And then you take them to recovery, you take them to ICU. And where do they usually measure that temperature on that patient? So a lot of times we do the lazy thing, right? Some places will do like the temporal probe, which is great because if you didn't cover their forehead, you could have had their whole body warm, but their head has been out exposed to that cold air, so their forehead's going to be cold. The other thing you'll see is that they'll use axillary temperatures. Well, we know axillary temperatures are notoriously wrong. Generally, they're off by at least a degree. Some of the thermometers compensate for that, so they'll put it into axillary mode. Or if the nurse puts it into axillary mode, it'll correct the temperature, but not always. I can't tell you how many times I've taken a patient out to the ICU, somebody that I brought out intubated, left the core temperature probe, whether it's nasal or esophageal, in place so they could get an accurate temperature measurement. And instead of using that, they are going to stick a thermometer in their armpit and document it. So it's kind of to your advantage that you make sure the temperature is not only corrected, but correctly documented. Because a lot of times it's tied into your financial compensation. So a lot of the groups, to try and put pressure on the providers to make sure we're doing all these things, will have a incentive-based compensation. So you'll get paid X amount, and then you'll have a bonus or some sort of extra pocket of money that you get for meeting all your core measures. So these are the big ones that are on there. Getting your patients out warm, making sure that your antibiotics are documented. There's only so many things that they really go after anesthesia for, and those are really the big ones. So it affects your bottom line if the PACU nurse or the ICU nurse documents an incorrect temperature because they were being lazy. So make sure for your patients that they're getting accurate vital signs documented in recovery or ICU or whatever, because you don't want to lose money for it, especially if you did everything you could. The other thing you'll see is look at where the patient started. So if you had somebody that came in to the operating room, maybe this was a trauma patient or a homeless person that was laying outside and it was cold, and they were already hypothermic, or maybe even somebody that's just septic. They were hypothermic when they got to you. You may have warmed them up from 93 to 94, but that's still below that 96-degree cutoff. So just make sure you document that, you did everything you could. The patient still didn't warm up, but they're warmer than what they started. So all those things are kind of beneficial for you. Yeah, Shelby and Wynn are laughing because I used to get all over people. Because it really does. You're going to lose money because somebody doesn't want to check the temperature correctly. But you can also consider core temperatures, so esophageal probes. If you have one in for the case, leave it in for the ICU to use. There's no reason to take it out. It's already paid for. If you're not getting accurate axillary temperatures, you can try doing an oral temperature. But if you have somebody that's post-procedure, they may become nauseated by having the thermometer shoved in their mouth. So that may not work. Like I said, a lot of places have gone to those temporal thermometers, which may be accurate or they may not. Like I said, a lot of times in the operating room, we have left the patient's head uncovered so they don't get warm artificially. You will see that the bear huggers have a little plastic grape that you can use to pull over the patient's head that'll help trap the temperature in there. And then finally, at Tyler's request, you may have to actually do a rectal temperature on these patients if they're that cold. All right, so that is the skip portion of today's lecture. I'm going to stop the recording right there. We'll take a break for about 10 minutes, and we'll come back and get into the IRIS stuff. Do you guys have any questions about anything we talked about so far?